Welcome, everyone. We are delighted that you have taken time to join us. My name is Russell Campbell. I am the director here at the Office of HIV/AIDS Network Coordination, or HANC, and we're based here in Seattle, Washington at the Fred Hutchinson Cancer Center. Today, we are going to be having a conversation about drug holidays, which have long been controversial when it comes to HIV medication. Recently, analytic treatment interruptions, or ATIs, have become more common in HIV clinical research. And ATIs involve medically monitored pauses in antiretroviral therapy for the research purpose of testing another HIV intervention. But ATIs, of course, as some of you may be aware, are not without challenges. So today we're going to be focusing on the second consensus statement on ATI recommendations, which was recently published in the Lancet HIV. And we have an amazing group of individuals who are going to be talking a bit about the second consensus statement. And we encourage you to share your reactions, concerns, questions with this group as this relates to future HIV research. So with us today, we have Thumbi Ndung'u, Karine Dube, Gail Graham, Ernest Moseki, and Jeff Taylor will be moderating. So without further ado, I will stop talking and turn it over to this amazing group of individuals who will be speaking with you today. And I encourage you to place your questions in the Q&A and or the chat so that we will have an opportunity to get to those as part of this discussion. Thank you.
Great, thank you, Russell. And I think we're starting with Thumbi. Is that correct? You want to go ahead and get your
that's correct.
Your slides up, and we can get the ball rolling. Thank you again, everyone, for joining. Terrific. We can see your slides. They are in presenter mode. If you can go into slideshow. Perfect. Great. It looks great. Go ahead.
All right. Thank you very much, Jeff. I just want to make sure that I know how to turn off my. I'd like to turn on my camera here because I may experience some bandwidth issues. Suddenly I can't do that. Okay. Thank you very much for this invitation to give this presentation on the recommendations from the second consensus workshop on analytical treatment interruption in HIV trials. Sorry, just 1 minute here. Okay, this diagram is taken from the International AIDS Society scientific plan that was published in 2021, and what it shows is that most HIV cure strategies currently being tested depend on basically using antiretroviral therapy for a time, and then interrupting antiretroviral therapy and intervening with various combinations that can boost the immune response. And when you do this, in order to test whether the intervention works, in order to cure HIV or to result in long-term control of HIV without antiretroviral therapy, you have to interrupt antiretroviral treatment, because at the moment we don't have any other biomarkers that would enable us to know whether the intervention has been successful or not. And so analytical treatment interruption is the only way now to test whether an intervention has really worked in terms of either curing somebody or at least inducing long-term control of HIV. Now, there are two kind of designs that we talk about when we talk about analytical treatment interruption. The first design involves interrupting antiretroviral treatment, and as soon as viral load becomes detectable, even at very low levels, you resume antiretroviral treatment immediately. So that kind of analytical treatment interruption has very minimal exposure to the virus because you start treatment as soon as possible, and there's very low risk of transmission. Inflammation risk is low, and generally it's considered to be fairly safe. The problem with this kind of approach is that it's not very informative from a scientific point of view, because we know that there are some people who experience viral rebound, and then after the viral load goes up for a while, they then subsequently control the virus, sometimes to undetectable levels, and in fact control for a long period of time. So this kind of ATI design is known as a set point, because you don't resume antiretroviral therapy immediately after viral load goes up. Rather, you wait until a prescribed viral load is reached before you resume antiretroviral treatment. However, the problem with this second approach is that it has some risks in terms of that transmission is possible. The virus can be transmitted. There might be some risk to the individual who is undergoing the analytical treatment interruption. And so these guidelines that we are going to talk about today are primarily talking about this second form of analytical treatment interruption, the set point one, where you allow the viral load to go up for a prolonged period of time before you resume antiretroviral treatment. And what I would like to say is that these guidelines had been developed previously. There was a meeting in 2019 that came up with some recommendations of how to do these trials. But this meeting was held in the US, and most of the participants in this meeting were people from the US who are doing these studies, mostly in the population in the US, which happened to be mostly white males. And so there is a need to include recommendations for low-income countries, as well as pediatric, as well as adolescent populations. And so with that in mind, we convened this second consensus workshop, and we had a planning committee. It involved 14 members. We divided ourselves into different subcommittees. There was a subcommittee that looked at eligibility criteria for ATI, how to design the ATI trial itself, as well as participant considerations and the pediatric considerations when doing ATIs. And so this workshop was held in 2024 in May in Nairobi, Kenya. There were 194 people who attended the meeting. They were drawn from scientists, clinicians, community advocates, people living with HIV, people who had participated in these trials, kind of trials before. And the paper that came out of this consensus workshop was published recently in Lancet HIV, and I'm going to be discussing very briefly some of the results from that workshop. So here are some of the questions that were asked at the meeting. First of all, are ATI studies appropriate? And most participants felt that they were in fact appropriate if participants are informed and understand the risks. And also, if we do everything we can to minimize the risk for participants and answer an important scientific question. We also asked whether placebo groups could be included in ATIs, and most participants supported this and said that inclusion depends on the study hypothesis and trial design, and if there are no historical controls that are available and the placebo is scientifically justified by sample size, that this could be done. Adverse events, it was consensus that this should be well documented, including adverse events that are as a result of the ATI itself, as opposed to the intervention. And then there was also consensus that for participants who do not meet the ART research criteria at the end of the trial, that this should be followed in a separate protocol. So what are some of the differences between the recommendations from 2019 compared to the ones in 2024? So for example, with eligibility criteria, CD4 count above 400 was meant to be the criteria for somebody to be included in an ATI trial from 2019 guidelines. And there was also other considerations like the NADA CD4 counts had to be above 200. In the 2024 recommendations, most people felt that because there's a lot of variation in CD4 counts, this should be region specific, although most participants in this felt that the CD4 count had to be above 400. The NADA CD4 count was thought to be something that could be excluded as a criteria for entry because most low and middle income countries settings do not in fact have the NADA CD4 count of participants. And so we would exclude a lot of people that would otherwise be willing to participate in these trials if we asked that there must be a NADA CD4 count above 400. I'm not going to go into all the other recommendations because of time, but there was also consensus, or at least a majority felt that other criteria could be a bit relaxed in order to allow more people to participate in these kinds of studies. But again, this has to be region specific. In terms of viral load monitoring, I think the guidelines are very similar to what was recommended in 2019. Viral load monitoring every week for at least 8 to 12 weeks. Allow for some viral load for up to 8 weeks. Some people felt it should be up to 4 weeks, but any viral load above 100,000, if it is confirmed, should trigger an ART restart. The CD4 monitoring criteria remains unchanged, and any CD4 count that falls below 350 should be cause for us to restart antiretroviral treatment. In terms of participant considerations, I think the main new recommendations are to make sure that we provide prevention services on study or refer participants to an established, reliable provider for PrEP to make sure that there is no HIV transmission during these kinds of trials, as well as more psychosocial monitoring and access to psychosocial services for participants in ATI trials. And I'm gonna not say too much about this because I know that Karine Dube, who is speaking after me, will expound a little bit more on this. There were no guidelines on pediatric and adolescents in the 2019 guidelines, other than that participants below the age of 2 years should be excluded from these trials. And the 2024 guidelines are again that participants less than 2 years should be excluded from these trials. But there are now criteria, established criteria that have been agreed upon from the 2024 recommendations. So in summary, the recommendations are that ATI trials are appropriate if the risks are known and minimized. There should be more regional considerations, including guidance on how to do ATIs in low and middle income countries, which is where most of these studies will be done. There are less restrictive recommendations in some areas based on current knowledge and the fact that we have much more experience with these kinds of trials. However, there is also consideration that these ATI recommendations need to be frequently updated as data becomes more available. And finally, I just wanted to say, what are we doing in Africa now that we have these recommendations? We are engaging in some responsive dialogues with communities to make sure that people understand about these recommendations and how to use them. So we have in 5 different countries, we are engaging in the responsive dialogues, but we are also doing some research activities on ethical rollout of analytical treatment interruptions in resource-limited settings, because there's still more knowledge to be gained from this kind of work. And finally, I just wanted to acknowledge all the participants in the workshop, as well as the planning committee. And I'm happy to engage in discussions and further deliberations on how we can use these recommendations to advance HIV cure research. Thank you very much.
Terrific. Thank you so much, Thumbi. That was a great overview and kind of explanation of how we got to where we are now. And now we're going to, thank you. Great. Karine is up and running. So we'll hand it over to Karine Dube. Go ahead.
Thank you so much, Jeff, and thank you, Prof. Thumbi, for such a great overview of the second ATI consensus recommendations. And so as Prof. Thumbi mentioned, the field has now shifted towards more person-centered considerations. So to go into more detail, what are the participant-centered considerations? We want to have more assessment of disclosures of HIV status and ATI participation, also providing disclosure support to participants, providing counseling on HIV transmission risk at all visits before and during ATIs, providing adherence counseling at our restart and at each visit until viral load resuppression, offering information about partner participant protections. Prof. Thumbi has already talked about PrEP, making sure it's available, including mental health assessments and support during the ATIs, engaging the community for input during the development of participant-facing materials, and including social behavioral research to address research questions that are relevant to the community. And as Thumbi mentioned, the consensus recommendations now include ATI-related AEs and the collection of social harm events during treatment interruptions. So prior to the May 2024 meeting, there was actually a series of engagement and webinars across 3 different time zones. So 6 webinars in total that were led by Dr. Chris Dedong, Michael Luella, Moses Supercharger, Matt Bromo, and Emil Udom, and I was also part of that, to really engage the community and understand their recommendations. Overall, 179 participants from 18 countries took part in these engagement activities. And some of the key takeaways were preferences for viral load monitoring frequencies that varied by region and the need for home-based viral load testing. So there's a world where we give the control back to the participants during treatment interruptions. A strong preference for inclusion of mental health screening and support, reducing the risk of HIV transmission and supporting participants and their partners, involving the community, disclosure support, local input, and understanding of ATI-related risks that should be assessed throughout the ATI trial. That's really thanks to Michael Luella, who led a session during the meeting on ATI-related risks, and also Richard Jeffries, who provided some of the data. And then, of course, inclusion of social behavioral research that was strongly supported. So I was asked to take a deeper dive into some of the participant considerations. So I wanted to show some empirical data from recently completed studies. This is part of our PERSIST program in the United States that is aimed at assessing and improving the quality of consent, but also evaluating the psychosocial experiences of HIV cure research trial participants before, during, and after their ATIs. And here we adopt a readiness and resilience framework. So on the resilience side, we are seeing accumulating evidence on the impact of ATI on the psychosocial health of participants. And so we know now that we must not only assess, but also support participants, particularly when it comes to partner protections. In the San Francisco study, 4 out of 7 participants experienced difficulties during extended ATIs. They were out of practice with these conversations and the EU era. It was really difficult to find out if partners were on PrEP. So we know we need a lot more implementation and implementation science around these considerations. We also learned that there is a lot of anxiety during treatment interruptions, usually associated with the uncertainty related to the possibility of post-intervention control. Currently in the ACTG, we are assessing participant experiences at 3 time points. This is a study done in collaboration with the HVTN and HPTN. It was a combination long-acting broadly neutralizing antibody trial across different sites in Africa. And so we're assessing mental health, perceptions of risks and benefits, and ATI trial experiences. There's also a post-intervention control cohort in the ACTG that is assessing the experience of people who have experienced post-intervention control, so who remain off treatment. Data from industry also showed that most of the impact of ATIs relate to the emotions, relationship, and mental health. And so this can only be assessed through the integration of robust participant-centered outcomes. But of course, we need more harmonization across. In the FRESH trial that was implemented in Durban, South Africa, and Prof. Thumbi is the principal investigator with Dr. Krista Dong, we were able to do a lot of empirical work to understand perceptions of treatment interruptions. We need to adopt a participant journey approach from the time of diagnosis, early treatment, to being part of a post-intervention control study. We were able to assess their experience at 4 time points here. And what we learned is that there are unique stressors for post-intervention controllers. In fact, the participants who experienced post-intervention control had the highest rates of anxiety and depression. And so we know we need to also support participants. The main stressors relate to the fear or the risk of HIV transmission, the viral rebound, and the uncertainty, ambiguity around our restart, having to disclose HIV, physical discomfort from repeated visits, and HIV-related stigma. But of course, participants bring tremendous strength into their ATI trial. They also receive a lot of support from the research staff and reframe their identity as a research partner and have tremendous scientific altruism. This is a manuscript on the impact of ATIs on sex behaviors during ATIs. So we know that participants have sex during an ATI, so we need to support them in negotiating safer sex with both partners with and without HIV, and assess the social harm events related to potential relationship complications. And so in this trial, we acknowledge upfront the psychological toll, the potential for trauma associated with viral rebound, and in this particular setting, the role of intimate partner violence. And so thanks to Dr. Ndung'u, we were able to provide psychosocial support, adopting a trauma-informed healing-centered design. We also learned from this research that staff needed specialized training to support participants' mental health during ATIs. And so we continue our assessments during different ATI trials from different modalities. But what we're really advocating for now is the establishment of a psychosocial safety infrastructure for ATI trials. We have very robust clinical data, lab infrastructure, but we also need to think about how we're going to support people who prepare for an ATI trials, who enter an ATI, and then who experience viral rebound, restart ART, and then the post-trial completion period. So this is a review of 35 different studies globally that we just submitted to the Journal of International AIDS Society. This is a global effort from people who are doing this type of work. So we also know that there's special attention needed for specific scenarios such as ATIs at ART initiation, placebo-controlled trials and crossover designs, extended ATIs or multiple ATIs, resource-limited settings. We need a lot of formative work, cell and gene therapy trials that are likely to have longer ATI periods, combination trials, third-party risks, and then also contemplating a new type of research that would involve interventional trials at the end of life. So once again, the field has shifted. This community, our community, has been very generous at providing recommendations as well. This was a stakeholder meeting that occurred in June of 2023, prior to the implementation of the 2 multi-site ATI trials that are implemented across Sub-Saharan Africa. But now we know that the times have shifted as well, and that the prevention and treatment infrastructure is getting dismantled. And so we really need to call for justice-informed HIV cure-related trials with treatment interruptions globally, and understand the impact, not just on participants and their partners, but also our affected community and the global HIV science. And so we have several questions for discussions for this group. How should the consensus recommendations be implemented in our AIDS-funded trial networks? Which ones are considered minimal standards versus aspirational best practice? What resources, training, or infrastructures are needed to support implementation? What should happen to ATI studies that are ongoing but do not yet incorporate some of these considerations? How should participant-centered considerations be incorporated in future trials? How do we monitor for this? How do we involve community and community advisory boards in implementing and refining the ATI recommendations? And then 7 to 8 years from now, what would successful implementation of ATI recommendations look like across the AIDS-funded trial networks? Thank you all so much. And Jeff, back to you. You're on mute, Jeff.
So sorry about that. Thank you, Karine. That was an excellent kind of deeper dive into the socio-behavioral aspects of of this topic. And kudos to you and your colleagues for all the great work that you've been doing around this and will continue to do. So next up, we have the pleasure of having Gail Graham and Ernest Moseki with us to kind of provide a community perspective on all the things that we've discussed thus far. So Gail and Ernest, if you're able to come on camera if possible. I know bandwidth issues may be a challenge, but if you can. And yeah, if each of you would like to kind of first give us your kind of top line ideas about what we were discussing and what do you think about these recommendations, and then we can delve a little bit deeper. So Gail, would you like to go first?
Sure. I think the recommendations for 2024 are great, especially the part where Karine was talking about the safety, psychosocial safety issues, because that's very important, that we need that from the beginning all the way to the end, and not just for the partners that's a part of the research, but for their partners in life, because they need to be included all the way through, because you do go through a lot of things. You go through the depression, and you go through you have comorbidities and different things that's happening at the same time. So the fact that you're adding mental health in there, I think, is a key point. The other issue I had was for children. They said they have to be 2 years and older. I think for me, I would be more comfortable if the kids were a little bit older than 2. If it started at maybe 5 or 7, I think that at that age, I'm just, as a mother, not comfortable with having my child participate in something like this. So that's just my thoughts.
Yeah, of course, that's a very personal decision, right? So completely understood. I see in the chat that Ernest mentioned that he's having some challenges coming off mute, so hopefully somebody can assist him with that. So in the meantime, I just noticed that there was a comment in the chat from Emily Smith saying how much they enjoyed Karine's presentation and asking if it's possible to link or a DOI to some of the papers that she mentioned. I know this is being recorded. I'm wondering if we know if the speakers would consent to also sharing their slides if possible. Go ahead, Karine.
Yeah, absolutely. We are more than happy to share manuscripts and slides and recommendations. Feel free to reach out. I can put my contact in the chat.
Terrific. Thank you for that.
And the
Ernest,
same thing with my slides.
Okay,
Sorry.
terrific. Thank you, Thumbi. No worries. And Ernest, were you able to get off mute and join us?
Yeah, can you hear me?
It's a little bit scratchy. Say a little bit more, and we'll see how well we can hear you. Can you speak a little bit more so we can see how your reception is?
It's quite scratchy from my end.
Yeah, this was happening before. Do you want to try logging off and logging back in again and see if that helps like it did last time? So sorry about that.
All right, then.
Always the challenges on these calls when we get people from all over. So Gail, I guess we'll go back to you and dive a little bit deeper while Ernest is overcoming his challenges. So let's jump down a little bit. So how do you think we should be operationalizing community input within the networks? You've had a lot of experience working in the networks. So how should we be doing that as we start planning new ATI trials? What are your thoughts on that?
I think we should include the community from the very beginning, from the very beginning of what we're thinking about for that trial. As we're going through, even for the confidentiality statements, we want to make sure the consents, we want to make sure that the consents are clear. I think that's a key thing, because the way some consents are worded, it's hard for people to understand. For something as severe as, for me, severe as doing the interruptions, we want to make sure that they understand exactly what's going to happen. I think that's very key. So that's why we need to make sure that we have community at the beginning as we develop it, and then as we disseminate the information so that it will go back to our community in a way that they can understand it.
Yeah, thank you for mentioning the consent process, because that's been, I think a real challenge for us as we've been moving through this. And these studies take a long time. They have a lot of moving pieces. It's not just, start this drug and let us know how it is. So do you think that we should do more than one consent? Obviously, you do one at the beginning, and these very sadly turn out to be, 20, 30-page documents as much as we try. So maybe when they start their ATI, when they go back on treatment, do you think those are other times that they should be reconsented?
Yes, I think they should be consented at the very beginning when, we start some type of medication before we stop the medicine. And then when we stop, go through the interruption, I think we need to do a consent then, make sure that everybody's on the same page and they understand what's getting ready to happen. And then at the end, when discussing the results, we want to make sure that everybody's comfortable with that information going out to the community.
Terrific, thank you. So I just want to remind everyone, if you have any questions, please put them in the chat. I don't know if we're able to raise hands or not, but we want to hear from people on the call as well. So it's not just us. And let me check in with Ernest to see if he's able to log back in. I'm not able to see the entire list of participants,
I
but
don't think he's rejoined us yet. So
okay.
We're waiting. Still.
Well, Gail, we'll continue our conversation with you then. Thank you for being so accommodating. So, we've been talking a lot, especially with Karine, on how we take what we know from our communities about this for the consensus statement and move towards operationalization at a time when we are also going through the recompetition, not to mention a lot of other challenges as we know right now. So, how do we navigate this in these times? What are your thoughts?
I think if we just keep the community updated with what's going on, I know that there's times where, like you said, the recompetition and sometimes things have to stop because of getting funding to continue and everything. I think as long as we update the community as we go through, or the participants as we go through what's happening, and then, realize that even though there's going to be some issues with funding, we're not stopping treatment as we're going through this interruption. We're still monitoring and everything. So that wouldn't stop. We still make sure the doctors are talking to them and mental health is being provided. But I think it's very important that we make that known, that even though we're going through different things in the world, if they're already started on this, that you will still maintain a good health care as far as with the providers, as far as with mental health, and with them following you through even after you finish the trials.
Yeah, and that just becomes all the more challenging, especially in places where healthcare funding has been cut or eliminated altogether. So it just makes the whole thing a lot more challenging. But any word from Ernest? If not, I do see a question in the chat from Shakina Rose asking that she recommends the HIV Basic 101 Coalition be informed in the informed consent process. So yeah, if you could put their contact there, that would be terrific. I think, sharing these guidelines and getting input from as many people as possible would be key in this process, especially since we're not able to move as quickly as we like right now because of the funding and other challenges. I think we can take advantage of that to, to work with other groups and get the word out like we're trying to today as well. I see from Brian, he's telling us that there are ATI trials being conducted in the networks with children below the age of 2, including infants rather, age 24. So the Tatelo and Tatelo Plus and the Impact Network. So since these studies are underway and ongoing, do you think the existing ATI guidelines should be applied for this population, or should they be revised and adapted for infants, or discontinued? So I think that's a question for both Thumbi and Karine, as well as Gail. So if you'd like to weigh in. Maybe start with Thumbi. Thank you.
Yeah. Thanks, Jeff. I'm going to have to say, first of all, I'm not very familiar with the details of the Tatelo study. My understanding was that they are giving children broadly neutralizing antibodies, but not interrupting antiretroviral treatment. But I could be wrong about that. Certainly, the vast majority of people who participated in the workshop felt that children under 2 years of age should not be part of ATIs, because when you interrupt antiretroviral treatment in children, there is a chance of affecting, I think, neurocognitive development in children. And so I think that was the consensus. So having said that, I do know that the SHARE study, the child who ended up controlling in the SHARE trial was somebody who actually interrupted treatment when they were below the age of 2. But I think the vast majority of people in this workshop felt that children below the age of 2 should not be part of ATI studies because of that risk to the children. So again, I need to go back and check and see what the rationale might be. If in fact they are interrupting, it could be that they're just giving an additional intervention with the broadly neutralizing antibodies without intervening. But I'm not 100% sure about that. So I probably need to check on that.
Yeah, Brian has kindly put the link to the trial. He did describe it as an ATI trial, so I think sounds like it is. But the link is there if you want to take a look. And then Karine, putting on your social behavioral research hat, how does this ring with you?
Yeah, I think this recommendation of not doing any ATIs below the age of 2 is actually consistent with the very first statement that came out in 2018, 2019. So that recommendation was pretty stable. At this meeting in May 2024, we discussed a lot of the social behavioral issues related to the infant and pediatric populations. So I think this group in particular will also need more social behavioral research. We discussed the issues of disclosure, particularly around HIV for younger people and what that means and at what age should we be thinking about disclosure. So lots of social behavioral issues to think about. But I think the broader question is, what do we do now that we have a new set of recommendations and that the needle has shifted? Do we go back and retrofit all ongoing trials to these recommendations? If we are making inclusion-exclusion criteria more lenient, do we also need to have a counterbalance? Everything has to be in balance and more support. So how do we, what do we do for ongoing trials? And then how do we build for future trials? And how do we go back to our existing protocol? I think it's a broader question for the field.
Yeah, that makes sense. Thank you. And then Gail, you talked about being
Jeff,
a mother. And I'm sorry, go ahead.
I just wanted to add that maybe one way to approach it from my perspective would be that these guidelines, these recommendations need to be presented now that they have been published to investigators who are starting new studies. So they need to have them on the table and discuss them with communities and decide what to do regarding particularly planned studies where, for example, they may not be in full agreement with these recommendations. And if there is rationale and justification for why those studies should go ahead, then they should. But if there is a strong feeling after those discussions among the community and together with the investigators that the studies should be changed as a result of these guidelines, then that should happen. And I just want to emphasize that point, that for me, there might be even issues that are in these recommendations that some communities may not be comfortable with. And so when investigators and communities are discussing new studies, these recommendations should be discussed. And if there are issues that a particular community feels they're not comfortable with, then they should change the criteria based on what the community are comfortable with. So these recommendations allow for us to be flexible to the local conditions and to really take into consideration what the communities themselves think about a particular set of recommendations. So if they are not comfortable, there should be some willingness to change these recommendations.
So a question for you now that makes perfect sense, and thank you for, and I think that was kind of the intent of this, right? That it come down to the communities and then they get to have their input. So obviously, if they're not comfortable with certain aspects of an ATI trial and want it to be more conservatively administered, that's one thing. What if they think that it's okay to be less conservative and maybe go beyond what these recommendations are? Do we think these recommendations should stop that, or do we allow communities to set the parameters in their own communities? That's
I
a
would
question
be
for
very,
everyone.
for me, just sorry, not to dominate the discussion, but I'll be a bit reluctant to say that we should relax the recommendations because these are set as minimum recommendations based on the best available scientific evidence. So a lot of the things that are in these recommendations, if participants are excluded, they are excluded for a reason, and that was based on whatever scientific evidence was available. So I would be a bit reluctant to say that we should relax these recommendations any further than what is in these guidelines. But I would be more leaning towards, if people want to tighten them a little bit more, then they should be freedom to tighten, but not to relax these recommendations. Otherwise, we might move into a dangerous zone where you are now tilting the more towards increasing risk for participants, which we don't want, because obviously all you need with this kind of studies is one or two bad incidents, things that go wrong, and it can be very bad for both the participants but also for the entire field. So I'd be very reluctant to relax these recommendations, but I can understand if communities feel that they need to tighten them based on local conditions. Yeah.
And Gail,
Jeff, I wanted to make you aware that Ernest is back on.
Okay, terrific. I know Gail was going to chime in both on that and kind of her thoughts as a mother for this particular trial. So go ahead, Gail.
Well, when the question that Brian brought up, he said that they're already below the age of 2, they're already in the ATI trials. So what I would say would be to actually update the parents about the new recommendations, and then go from there. If they want to tighten it up, follow through with that, or continue with things as is, but they need to know everything about it and then make their own decisions from there. But again, as a parent, with as Karine brought out about the neurological effects of different as the kids are growing up, especially at that young age, I would not be comfortable with that at all. And as far as relaxing the new recommendations, I would not be comfortable with that. I'll be, as Thumbi said, to maybe tighten it up a little bit more, especially when you're doing the blood work for the viral load, because we're looking at stuff at a longer pace, and we don't know what the effects will be. We know with the short term, when we do the short study, but now we're looking at elongating the study, and we don't know what health issues will come up with it. So I think we need to just be very careful and keep up with the blood work to make sure that there's nothing new popping up that's not affecting any other organs or whatever as we're coming off the medication and then going back on the medications.
Right. Great. Thank you for that. And Ernest, welcome back. I'm glad you were able to get back on. So I'm going to go back to the original question just to get kind of your thoughts about the recommendations and kind of what they mean to you and the communities that you work with. So go ahead, Ernest.
Thank you. Tell me if you can hear me.
Yes, we can hear you perfectly now.
Thank you. The recommendations are, for me, the starting point and a strong foundation for starting point for ensuring the safety of ATIs. And I really like what Prof. Thumbi said in terms of what he believes people or communities or settings should do in terms of not relaxing what we currently have, but rather sticking with it or increasing the bar slightly higher. I believe that we really need to, as community and as sites, to find a way of taking these recommendations out of research settings into communities so that they understand that there is existence of these communities, and perhaps assess them in terms of adequacy. Are they adequate? Do we need to add something? Do we need to make them a little bit stricter? And the issue of younger children being enrolled in ATI studies is a very big one, and it should come with certain requirements, such as neurocognitive development assessment that is important in children. Which we are not, unfortunately, we are not seeing in some of the studies that enroll younger children. I wish it's something that we can put out there and be part of the recommendation, so that we are at least comfortable that there is a recommendation out there, even though it's not a guidance. Some people might choose to implement, others may choose not to do so.
Great, thank you for that. And then one other question that I think we have to ask is, are there any gaps? As we talk about this and think about different situations in different populations, are there gaps in these recommendations that we need to acknowledge and then work on? And looks like we're going to be updating these on a periodic basis as we have been. So what have we missed? So feel free for anyone to chime in on that. Or I can call on someone. Karine, do you have any thoughts?
I think,
go ahead. Go ahead, Thumbi.
I can opine here. I think one of the things that we don't fully understand, in my view, is what the treatment interruptions do to, for example, something like the reservoir. So when the idea behind HIV cure is that you want to eliminate the reservoir, and so you don't want to increase the size of the reservoir to an extent that is clinically significant. At the moment, we just don't know what is clinically significant in terms of the reservoir. When somebody interrupts treatment, you expect that the reservoir might go up, but how high does it go up, and is that clinically significant? So, and also, once somebody goes on antiretroviral treatment, does the reservoir go back to what it was before? Because that's what ideally you would at least want, is that you have lowered the reservoir to what it was before the treatment interruption. So I think that this is a question that we should address as a field going forward with some of the studies that are being done, and it will help us to know what is safe, where are we in terms of safety, because at the moment it's not very clear. So I think that's one thing. The other thing is that these markers of, I think when somebody interrupts treatment, you might expect again, and I'm speculating here, but you might expect that markers of inflammation or even biomarkers that have been associated with something like brain health might be altered and might go up because somebody is being exposed. There's some level of exposure to the virus. Now, if that exposure to the virus is then going to result in good immune responses that control the virus, you could say that that's a risk that is worth taking from the perspective that it is going to lead to long-term control. But is that going to result in any kind of harmful clinical effect over the long term? I think those are things that we need to know. And the only way to do that is to combine, for example, samples from these ATI studies so that they can be studied and we can understand what is going on with those sort of biomarkers, parameters. And I think it will provide more reassurance to the field, or it will cause us to change the recommendations accordingly. Right. Because if some new knowledge comes along that is useful and helpful to the field and is pointing in one direction, we should definitely be willing to change and move in that direction. But I think there's a lot that we don't know. Yeah.
Great, thank you. Turn to our community folks now. What do you think about it? Are there any gaps that you see in these, and kind of how should we address those? So, Gail or Ernest?
Yeah.
I'm sorry. Go ahead, Ernest.
Thank you. I don't see a lot of gaps. However, due to changing socioeconomic, geopolitical issues, we might want to go back and say, how then, for example, do we ensure that there is continuous, because the recommendation talks about continuous community education, community engagement. How do we ensure that it really happens from the standpoint of resources? For the better part, engagement has been linked to a specific protocol in terms of resources. We however saw there was a little bit of change. There was talk of engagement outside of protocols, which unfortunately has been affected by what is happening due to funding. The other thing that worries me big time is availability of PrEP and PEP, which at least where I am is a challenge accessing, not only from the site, from the research organization's perspective, but in terms of national availability of such commodities. So I think we might have to go back to the drawing board and talk about how do we ensure that these are really available for ATI participants, for ATI participants partners, so that we do not necessarily expose participants and partners to risk.
Of course, yeah, and it's so challenging right now. I can only imagine. Gail, go ahead. I know you got some comments as well.
Oh, I agree with Ernest said. I really didn't see too many gaps, but I did appreciate the partner protection. I appreciated that a lot. I think that is the key. We have to make sure that the partners are aware of PEP and PrEP throughout the entire time, to talk to them, to make sure that they're still comfortable when we go off the medication, because there's a lot of anxiety. Also, we need to talk about disclosure. I think that's key too while we're doing this. With the stigma and everything, we want to make sure that our partners who are participating is clear with the fact of disclosure when they come off of medication, so for the safety of their partners, and then the fact of the partners being comfortable with the other partner being comfortable with them coming off too, and being able to disclose what's happening in their life too.
Yeah, I mean, especially in some communities, there are high rates of intimate partner violence, and we want to be able to protect, our participants from that and give them the tools they need to navigate that.
Jeff?
So, yeah, go ahead, Karine.
When we did this, we studied partners in Durban, South Africa. Outside of the study, we learned that not just partners without HIV, but also partners with HIV had health and informational needs during the ATI. So of course, for Partners Without HIV, it's the need for prevention, like HIV testing, prevention, initiation, and persistence. They had a lot of questions about on-demand PrEP, for example. For Partners with HIV, the questions were a little bit different. They were themselves worried about their own detectability and viral suppression. And that was in 2024, 2025, before we know what happened. So we can only think about how these concerns may be heightened now. They were very invested in the ATI trial outcome as well, and they did not want to interfere with the main endpoint, which has to do with viremia. And so I think we need to think about participation holistically, not just the people who signed the informed consent, but also the people around them who will be supporting them, because partners also have a really important role to play in the retention of participants in the trial. So thank you.
Yeah, I think you raise an important point. We need to be thinking about the community writ large and not just about the participants, but the environment in which they're living and operating. So I just wanted to bring to people's attention that Ron Bosch had provided some great resources in the chat in response to some of Thumbi's comments. So I would encourage people to look at those. And then another thing in the chat is, so we're talking about, some of the challenges, and Mark Franca, the Dusseldorf patient, wrote in the chat that one of the challenges he had was that his study site was 2 hours away. And of course, that became very challenging to, as he was embarking on his ATI to go and get tested. So they taught him to do it at home. So I think this raises an excellent point that we need to be really flexible about how we do this and empower patients to do as much as they can on their own. I know one of the things the field really needs is, point of care testing, right? So people can do it where they are and not have to travel long distances to a clinic. So yeah, great point, Mark. Thank you for raising that. And then Patricia Segura asked, what are the recommendations? I'm sorry, go ahead.
Just a time check that there are 4 minutes remaining.
Right.
If you want to allow final thoughts. Thank you.
Yeah, thanks. There's one last question I wanted to address. So what are the recommendations about new STIs during the ATI phase? So how do we address those? So maybe that's a Karine or Thumbi question. Any thoughts on that?
The recommendations that I recall, I'm trying to see whether I can quickly look at what the recommendations actually in the paper say, but I recall that STI testing is every 8 to 12 weeks at least. It can be more, but if a new STI is noted during the trial, the recommendation is to provide support and of course treatment for that STI, not necessary to stop the person from participating in the ATI, because it could be coming from different sources. It could be a recurrent STI. So the recommendation was that we do testing every 8 weeks or so, but the person can continue, but of course with support to deal with that STI if there's a new STI during an ATI. Yeah.
Great, thank you for that. So yeah, we are at the end, as Russell said. So if each of you would like to give a kind of a 30-second summary of final thoughts. We'll start with you, Ernest, and go through community and then through our scientific partners as well. So go ahead, Ernest. Any final thoughts?
The recommendations keep on evolving as we learn new things, and therefore we need to be closer to our communities and continue with education, with engagement. And finally, a human being who enrolls into a study has social structures around them, and therefore it's important that these are highlighted in the recommendation to ensure that there is support and there is engagement with this person's support structure. Thank you.
Terrific. Thank you for that. Gail, how about you?
I agree 100% with what Ernest said, and I just give my time to Karine and then Thumbi.
Thank you.
Thank you. I think we need community at the table. We need to implement the participants and considerations and put people at the center. And I personally think we need fewer but better supported clinical trials, both domestically and internationally. We need to develop the infrastructure and do this the right way with the right level of community, constituent engagement, and formative research leading up to the ATI trial, because even the times have shifted. So these recommendations were published earlier this year, but the meeting happened in 2024. So what if we did this meeting again this year? What would the recommendations look like? So we need to keep asking the questions of what makes ATIs ethical. Thank you.
Great, thank you for that, Karine. And then Thumbi, I think you get the final word.
Yeah, I think that there needs to be dialogue with communities about these recommendations. And I feel that any kind of hesitancy, any kind of resistance should be documented, and so that we know what the rationale for that, because that dialogue and communication between communities and investigators and researchers will only improve the field and will work very well for the field, so that we can know what the reason for the reluctance might be, and that will only help to improve the field.
Terrific. Thank you. Great way to end this. So thank you again to all of our panelists, Thumbi, Karine, Gail, and Ernest, and to all of you for joining and for the great participation in the chat and all the information you've shared. So thank you all.
And thank you, Jeff.
Thank you. Bye, everyone.
Thank you.
Everyone.
Thank you. Bye.